Well, thank you. Just want to take a second to remind everyone that it was almost 50 years ago, half a century ago, when we made a decision that we would spend our time, our effort, and our money screening for Down syndrome. I also want to remind you, at that same time, this is what a karyotype on a prenatal sample was still looking like. Just beginning to band, and in many cases not banded. And those of you who remember, and I'm sure Jean does, we used to fight sometimes about whether it was a 21 or a 22 because we only separated them on size. This was half a decade ago, yet what are we screening for now? We're still spending most of our time, our effort, and our money screening for trisomy 21. Despite the fact that we have moved in gigantic strides over what we possibly could be screening for. Certainly, we went from poorly banded chromosomes to well-banded chromosomes, and we've improved the resolution to somewhere in prenatal karyotypes anywhere around 10 million base pairs. Excuse me. Dramatically improved, but certainly we can do better. We then moved, as Tony discussed, to microarrays, and we now know that although we may not always do it in prenatal testing, we have a resolution that can be in the kilobase range, so that we can also identify much smaller changes. And today, we have the ability to analyze fetal tissue with a resolution at a single base pair. So isn't it really time that we take a step back and ask the question, where should we be looking and what should we be looking for? And I just want to call your attention to the fact that one can't even justify just looking for Down syndrome on the basis of frequency of disease. This is the birth frequency and prevalence of congenital anomalies. The common trisomies occur in about 1 in 500 pregnancies. Other chromosome abnormalities other than trisomy 21 are just about as frequent if you look at all ages, all maternal ages. As Tony just said, microdeletions and duplications, not all of them, just pathogenic ones, are about 5 to 6-fold higher in the general population. Jim already told you about there being a higher frequency of Mendelian disorders, and really the 900-pound elephant in the room that we don't talk about is a large percentage of these anomalies are structural, and for a high percentage of them, it's highly likely that these are single gene de novo mutations, which really is what we're going to talk a little bit about today. Before I do that, I do want to take the transition from microarray to sequencing or exome sequencing by reminding you, because when we talk about arrays, we talk about kind of a very homogeneous group of disorders. But to remind you that there are a number of microdeletion syndromes, too small to be identified by karyotype, but that really have phenotypes that no one can argue are not very severe, and many would agree much more severe than the phenotypes we see with trisomy 21. And we've already mentioned a number of these: Miller-Dieker syndrome, Smith-Magenis syndrome, etc. Also, however, there are non-syndromal microdeletions, usually smaller, in the 600 to about 1 or 2 mega base pair, that have associations not with complete syndromes, but with things like autism, but some microcephaly, schizophrenia, etc. So microdeletions have a very large spectrum of phenotypes. So I don't think it should be, and I think a lot of our patients misconstrue that this is smaller, it's less important, but that's really not the case. There really are very, very pathogenic and significant microdeletion syndromes. The other thing, while we're talking about the smaller, or what we used to call the predisposition copy number variants, like the 16p11.2, etc., remember that most of these were initially described when one was looking for a particular disorder. Many of them were described in series when one was looking for autism. Some were described when people were looking for schizophrenia, etc. And there was it appears, a misconception that these were relatively non-penetrant, because if you were looking for a disease for autism, and you didn't have autism, then you would say it wasn't penetrant for that. But the important thing that we've learned over time is these have a very large, significant phenotype associated with disordered brain development. And I've listed here the very common microdeletions that we see, and you can see almost every one is associated in some people with intellectual disability, some with autism, some with schizophrenia, some with epilepsy. So indeed, it appears that the vast majority of these are penetrant, but they're not consistent or have a relatively wider effect. And I think learning about that has been very important, and it's taken away some of the angst that I really have to talk to patients about non-penetrant disorders. The place that microdeletions, and I agree with everything that Tony says, have really been valuable have been in looking at fetal structural anomalies, and that would be the group on the right, the ones that are the syndromal ones. And we have a series now of 1,762 fetal structural anomalies, and I just thought I would put into perspective the role that microdeletions play. Overall, of those 1,762, about 21 in 4 of any, and these are sequential structural anomalies, 1 in 4 has a cytogenetic abnormality of one kind or another. And unquestionably, when you're looking at structural anomalies, abnormal karyotypes are more frequent. They're about 20%, 21%. But pathogenic CNVs in this series were about 3.5%. But I think this number over here is what we really care about, and that is, of all the structural anomalies that had a cytogenetic abnormality, 1 in 7 of those are a copy number variant and would not be identified if you only did karyotyping and not microarray. Also point out here that really varies by the organ system that's involved, and the heart, the kidneys, and CNS, you can see, have over the 6%. And for each of these, of all the cytogenetic abnormalities, 1 in 4 of those are actually copy number variants, not whole chromosomal abnormalities. And nuchal translucency, again, is not as revealing. They have a high frequency of cytogenetic abnormalities, but the majority of those are whole chromosome aneuploidies. So indeed, we now know that this is very important information. And in the States, and the American College of OBGYN suggests microarray should be the primary test that's performed if you're doing a procedure for a structural anomaly. 2 other points about microarray, and then we'll move to sequencing. I just want to point out how important this is to patient counseling. And we all know that you see a fetus with a cardiac abnormality, and it's not infrequent that the patient's told that our cardiac surgeons can fix that. It's not really going to be a problem. But again, we know that a high percentage of these, and the highest that have a copy number variant, have 22q11.2, and certainly the cardiac abnormality that that fetus has can be fixed. But look at all the other things that are associated with that, and really are not cardiac at all. there's a high incidence. The vast majority have learning disabilities, about a third of them severe learning disabilities. But some of the things that we never had to think about, 1 in 4 individuals with 22q11.2 by late adolescence or early adulthood have severe mental illness and schizophrenia. Who would have ever thought the same gene that was causing these heart defects was so strongly related with the same genes that are causing schizophrenia, for number one. But number two, if you talk to the individuals that take care of these children at the large 22q centers, it's the schizophrenia that really has been most difficult for the families to handle and the families to deal with. So having this information really allows us to give very important counseling to the parents about what this really means. So it really, in my opinion, can't be justified to get as much information as possible so they can make the important decisions about prognosis, etc. The last point that Tony alluded to is, should we be offering microarray to everybody? And 5 years ago, when NIPT started, the NIPT company said, oh, no, microarrays aren't important because they couldn't measure them. They couldn't screen for them. Now, all of you who work with microarray companies know they're all scattering to identify microarrays during their screening because we do know how important they can be. So this is just from 2 series that we've now done of just under 6,000 patients. I've listed only here pathogenic CNVs. In other words, ones that have been well documented in the literature, ones that have a specific, well-defined phenotype, and they occur at about 1 in 80 to 1 in 90 pregnancies. So if you think about that, that number seems high, but about 3% of children need remedial care at the age of 3 because of developmental difficulties. And about, 15% need care, and 1 in 3 have severe intellectual disability. So this number is not high. This is just the recognizable portion that we're now getting to for that particular group of children that have difficulties. Again, this is the frequency of trisomy 21. This is the frequency of microdeletions. And you can see not until the age of 40 is the frequency of Down syndrome the same or higher than the frequency of microdeletions. Yet we spend a lot of time looking for Down syndrome without paying attention to an equally, if much more frequent, cytogenetic abnormality. The other point is, here is listed on this side the top 10 copy number variants that are referred to a pediatric geneticist or a developmentalist. This is the pathology that go to be evaluated as children, and here's the list of the copy number variants. Here is our list of the copy number variants that we have found when we do invasive diagnostic testing with microarray on all patients. In other words, not patients with structural anomalies, on the entire population. They're the exact same list, demonstrating that what we are identifying by looking at this in all patients is the same diseases that are causing problems for these children and are causing significant developmental delay. So there really is no disconnect. We are finding important genetic information if we looked for copy number variants in the entire population. Now, obviously, the question I get is, why do I want to know this? What can I do about it? And I think it's important that all of us realize the time in which prenatal diagnosis had 2 options has disappeared. Prenatal diagnosis used to be, you take the information and you continue the pregnancy, or you take the information and you terminate the pregnancy. We are way too sophisticated, and we're only going to get more sophisticated as our tools get better. There are lots of options for the children that are identified with this. They can have early intervention for learning disorders. There's information about autism that the earlier you start treatment, the better the long-term prognosis. So one says, well, then why don't we just do this at birth? The answer is, and I demonstrated early, some of these copy number variants have very severe phenotypes, and patients have the right to have that information. But you will find lots of these, and knowing these things before they're symptomatic absolutely allows you to make a significant difference in the growth of that child. And about 3 out of 4 of our patients in whom we talk to them about a copy number variant take the information, say, I'm going to tell my pediatrician, I'm going to develop a treatment plan, thank you very much. So I think we just got to expand what we think our role is. We're not doing prenatal testing, we're really evaluating or doing the earliest precision medicine for children and identifying in fetuses what kind of care they're ultimately going to need. Okay, so that's my thoughts on copy number variants, but I just wanted to transition. Sequencing, and Mark showed this clearly, that the cost has dramatically come down. I was recently at a meeting where someone was saying they could do sequencing, whole exome sequencing, for $300. So it's going to continue to get lower, and that's why we now can talk about it as a clinical test, which it has in many centers already become. Also, sequencers are available at, I don't know any facilities now, at least in the States, that at least don't have a sequencer. They may not know what to do with the information when they get out, but it's become a very common tool. And sequencing itself is just now a commodity, and the price is just coming down. So let's talk about how we can use that in prenatal testing, in prenatal diagnosis, and I'm going to limit myself to talking about exome sequencing, not whole genome. Many of you know that there's arguments about whether we should look at the entire genome or whether we should look at just the coding areas, which is exome sequencing. Right now, we're doing whole exome. The main reasons are twofold. Number one, it's less expensive, and number two, it's just too difficult right now to really, for clinical use, interpret all the information you're going to get from whole genome sequencing. The bioinformatics is difficult. Whether we go there or not is going to depend on what we find in investigations. Okay, this is my first experience. This is 4 years ago now. With whole exome sequencing. This is a fetus, and I think everyone in the room can see this is the heel, this is the foot, and these are the toes. And you might not be able to count them, but there's a lot of them. I think there's 8. Here's the other foot, got a lot of toes, and there's a gap there, and there's what looks like the big toe. So this was what we saw on ultrasound, and this is the differential diagnosis. And if you look at the differential diagnosis of polysyndactyly, you can see that there are some disorders that are really severe phenotypes. It could be Fanconi's anemia, it could be A syndrome, it could be a number of these disorders, yet some of them are only peripheral disorders with no cognitive implications, and that's what our patients care about. They want to know whether or not their child is going to develop normally. So with this differential, there was no question the patient was considering not continuing the pregnancy. We said, well, why don't we do sequencing? Because again, we had just kind of started doing that. The sequence analysis showed a mutation in the sonic hedgehog gene. As many of you know, sonic hedgehog's involved in limb development. The specific mutation was associated with triphalangeal thumb, with polysyndactyly. These children do great developmentally. They just really need to have the limbs fixed cognitively. Their impact changed her whole mind, continued the pregnancy, and as we counted, you can see how many toes there were, and this what looked like the big toe actually was just a large middle toe. These are just the hands. So in that particular case, there's no question that the course of the pregnancy was changed because of the information that we got from sequencing that we would not have known in any other way. Since that time, there have been a number of studies that have appeared in the literature about the value, and all these are exome sequencing, of the value on undiagnosable diseases. And I think Mark mentioned this too, where you have a kid that you just don't know what's wrong with it, or an adult who's deteriorating and you just don't know why, or a fetus like we had with multiple anomalies. So these are the studies that have appeared in the literature. They're really heterogeneous. And you can see that some were ascertained because of neurologic, mitochondrial, intellectual disabilities, etc. And the percentage of those undiagnosed diseases on average that were able to be resolved by doing whole exome sequencing is just under 30%. You can see the highest is around 45%, and neurometabolic was about 70%. However, there's our 2 points to make. Although there were a few fetuses in here, these are almost predominantly postnatal cases. And second of all, they're cases in which the pediatric clinical geneticist said, I think that this may be a single gene disorder. And those of you that work, as many of us do, with really good clinical geneticists, they are so good at being able to say, well, this might be this syndrome, this might be this syndrome. So this is a highly, highly selected group of pregnancies in which you can get 35 to 40%. Our question was a little bit different. Our question was, if you took any patient that walked into a prenatal diagnosis center with a structural anomaly, and just like we're suggesting one does with copy number variants or microarrays, you did exome sequencing, and we called a structural anomaly any structural abnormality plus a nucleotranslucency over 3.5. So we approached those patients, got informed consent to do exome sequencing, and first did a karyotype and an array, and if that was abnormal, we stopped. But in the vast majority of cases, we went on and did whole exome sequencing on a trio, because we were looking predominantly for de novo mutations and having samples from the mother and the father, which to compare the fetal sample to becomes much easier. Now, of all the patients we approached, about 70% said, sure, why don't we want to do exome sequencing? So it was relatively accepted by the patients, despite the fact we told them all the stuff that you usually tell people when you're going to do sequencing, about unknown findings, about adult diseases, etc. So this is our results. We have about another 50 cases, but this is just about our first 96 cases. And you can see that of single anomalies, the fetus had a single anomaly, about 3% had a pathogenic, well-proven, described in the literature, causative deletion, variant. If they had multiple anomalies, it was 1 in 5 or more. So overall, it was 9%. But I want to call your attention to this column. These are hot, what we call at our place, hot zone mutations. They are mutations that are in a known intolerant gene, in other words, a gene that does not well tolerate changes, a conserved gene, loss of function, but despite the fact the gene is screaming out at you, I may be causing the problem, it had not yet been discussed in the literature. The pathology and path words weren't well described. So this is a very conservative approach. So if you got and wanted to include likely, these numbers would go up to almost 25% would we be able to resolve. But obviously it's just going to take us time to prove this. And not only time, it's going to take us data. We need large databases for fetuses, just like we have needed for copy number variants. The other thing we found, that we have a large series of patients that do not have any structural anomalies, and we looked at all the de novo mutations in that group and the de novo mutations, including anything we found in the group with anomalies, and there was a dramatically statistically increased incidence of de novo mutations, although we couldn't say all of them were causative. What did we find? Well, listed here, CNS was most common. And some of these findings, you can say, were so straightforward, you maybe could have done a panel or done it another way. In other words, we had agenesis of the corpus callosum with an L1 cam. We had a case of thanatophoric dysplasia. So that some of these were really pretty straightforward. They're not the ones I want to talk about. I want to talk about some of the difficulties we had or some of the things we learned that points out this is not going to be as easy, but it's certainly going to be more intellectually fulfilling than we had thought. So this is the first case. This woman walked into our office at 12 weeks gestation with a massive cystic hygroma and massive hydrops. I mean, those of you who do ultrasound, there was edema around the whole fetus. So we said to her, this is a really bad prognosis. She said, I don't care. I'm going to continue the pregnancy. At least let's see where this goes. So she came back at 18 weeks pregnant. The fetus, for all intents and purposes, looked entirely normal, which surprised the heck out of us, except for this. This is the heel. These are the toes. This is the proximal portion of the foot, and this kid had proximal foot edema bilaterally. So it was incredibly unusual, and we thought we knew what it was, but she then had... She was part of our sequencing study. The child had haploinsufficiency of the FOXC2 variant. This variant is well known to be associated with the lymphatic system. Some variants of this are associated with Milroy's disease. Yeah, Milroy's. And actually, other than the foot, it's going to be fine. Why do I show this? I show this to demonstrate that we're going to have to learn about the phenotypic development of these kids. We know most what we've seen in the nursery, but lots of these things are going to look very different in utero, and the genes that we see for fetal anomalies are not going to be what we spent years learning about looking at postnatal kids. In this pregnancy, the only thing that this child would have would be leg edema, and Yuval had a similar case, and there have been other cases now that have been described. Not all the same gene, but all genes in the lymphatic system. Here's a case that I think most of you can see is not normal. This child has large cystic hygroma, also has hydranencephaly. The brain's just gone. There's really just fluid in the brain. And then this is the knee, this is the foot, this is one foot. And right here coming at us is the other leg. It's kind of twisted up like this. This fetus died shortly thereafter in utero. And she said, is there some testing you want to do? He said, your karyotype's okay. And she actually had heard about sequencing. He said, don't worry about it. It'll never happen again. Here's the second pregnancy, identical. The fetus has hydranencephaly. It has the massive edema. And it also has the legs crossed over. It's almost a phenotype, a phenocopy of the last one that we saw. And this fetus, both of them had the FLV-CRT. They were compound heterozygotes, meaning she's got a 1 in 4 chance that this could happen again. So we actually were able to give her good information about a future pregnancy. But we also learned this gene is associated with proliferative vasculopathies. And it's surely the vasculopathy was causing interference of the blood flow to the brain and to other organs, and that's why the fetuses don't die. So again, with this, we're going to have to learn the phenotypes, we're learning an incredible amount of developmental biology, and we're helping parents. But it's not always that easy. Here's a case of hydrocephalus, and we see hydrocephalus, all of us. It's a very routine diagnosis. You can see here's the midline of the brain, there's the large ventricle, and she was part of the study, and she had an MYH10 de novo loss of function mutation. MYH10 is myosin heavy chain 10. It's a myosin, but a non-muscle myosin. But the thing about it is it's enriched in neural tissue during mouse development, and it's critical for neural migration into the cerebral cortex. I think that there's, we all hear about 6 degrees of separation. Well, between a gene and a structural abnormality, if you try hard enough, you can, through 6 degrees of separation in your head, make up a way that they may be related. So just seeing a gene and a pathway that makes sense is not sufficient. So that when we're interpreting these, we really have to have a fair amount of proof. So in this case, there was another piece of information, one article in the literature. It was a de novo mutation of a different gene in MYH10, or in MYH10, a different allele. And in the mouse, it looks just like this. The mouse has intrauterine growth restriction. It has severe brain malformations. And in this one case in the human, they saw the same thing. So now we have one other case report. We have a mouse model that's, again, got CNS abnormalities, although not identical. And we have our case. So is that sufficient to say that this gene caused that? We still don't think so. Although last month there were 4 other cases of the same gene associated with fetal malformations, but not the exact ones we see here. And the point I'm trying to make is that we really have to be careful, and we really have to get the time to make sure the associations we think. And a lot of those series I showed you earlier that have 60%, they include a lot of, well, it makes sense. Well, it makes sense when you look at series, you really got to make sure that's not how they're calling it, because those numbers will be higher. There really takes to be a lot of information. The second thing is, and this is a begging, all of us that do prenatal testing with sequencing, we've got to get a common database, and we've got to phenotype these kids in a consistent way so we can learn all of this. The other thing that becomes important is that a lot of these, the vast majority, as I said, come from de novo mutations. And here I want to point out that this is the risk of a de novo mutation based on the age of the father. And you can see as a man ages, his risk of having a child with a de novo mutation increases. In red are intergenetic, and in blue is not in the genes. And you can see the slope of the red line, those that are within genes, increases more sharply. So as men get older, the frequency of their children having de novo mutations will continue to increase. And between the ages of 20 to 40, the number of de novo mutations increases by 4%. So that means every 16 years, it's going to double. This is the age of men having babies, and I don't have to tell anybody, older men are also, the age of men having babies is increasing. So the ability to identify de novo mutations is going to become ever increasing, and probably it's much more common even now, de novo mutations, than is trisomy 21. Just to give you some perspective, this is the risk of achondroplasia, which is well documented to increase with paternal age. And you can see a man over 50 has a almost an 8 times greater risk compared to a 20-year-old, which is the basis. And you can see how that risk goes up with age. Apert, Pfeiffer's, the FGFR3 mutation. So there's absolutely no question. A little anecdote. I have a patient who is 76 years old, and has all the money one could want. A multi-billionaire, and he has a new wife who's 26. And she looks just like you think she would. And he came to us because he's really, really smart. And he said, look, I'm really old. And I read on the internet that as I get older, I'm going to have these de novo mutations. What I want you to do is I want you to sequence me. I want you to sequence my wife. And then we're going to get pregnant. Well, we're going to hire a surrogate to get pregnant, because when you're that rich, you don't have to carry your own baby. We're going to hire a surrogate, she's going to have a CVS, and then you're going to look for de novo mutations. So that's the power of this information, and that's how it has gotten already into the population, that people are asking us to do that. So I guarantee that won't be the last time we'll be asked, and I'm sure that there will be opinions coming out that we really need to look at de novo mutations. Now, what I want to point out in closing is this can already be done non-invasively. As you know, there are 2 publications that showed that you can basically sequence a fetus in utero by using haplotypes, but it will take like 6 months to a year. There's some information now that demonstrates that you actually can identify those fragments of cell-free DNA, which organ they come from, and if we can get that down using methylation markers, we might even be able to just look at fetal DNA fragments and then sequence them. But coming soon to a neighborhood, and I have no relationships with any company, I just was told about this last week, that there is now a company that is going to start offering non-invasive testing for de novo mutations. They right now are using a technique in which they're going to do 30 de novo mutations, and I've just listed those here. But you can see this is just the beginning, how this will expand. Does it make sense? In my opinion, it makes more sense than looking for Down syndrome in everybody, because de novo mutations occur with more frequently, albeit more frequent in older fathers. And what's on the list is what you would expect, and I'm sure everyone will be aware of this. So basically, we keep moving. We keep getting really good technologies. Our job is to, in most cases, decide the best way to use them and how to answer the questions that our patients are asking. And now you can say lunch, lunch, lunch. No! Oh, my God. Okay, thank you.